extremely appreciated. Thank you very. So, if you could click on the exactly questions, then thank you for doing that. There are a couple of questions, and one question which I would start with, which is a little bit more general, coming from a couple of people already earlier, it's about current state of the concept for exercise. And you, Barry, already mentioned this importantly. Then years ago, we were very conservative in terms of how we could propose participation in school, varsity, or whatever other activities. Over years, ideas evolved slowly, and nowadays it's becoming more and more probably liberal. There was a press release a week ago of the study by Dr. Ackerman from Mayo Clinic and maybe with Yale, if I remember together, they explored the questioning high-level athletes, and high-level athletes were allowed to return with 2/3 with hypertrophic cardiomyopathy and 1/3 with long QT, if I remember right. And over years of follow-up, out of 76 subjects, only 4 developed ICD therapy. One of those was long QT, but other not. And altogether, this paper kind of stressed that maybe like Dr. Sears showed, the soccer player who was resuscitated and subsequently came back to play at World Cup. The same story is right now, looks like coming on other therapies and other patients. So questions probably will start with Mehmet and with David and everybody else on the topic of how do you approach these days exercise and question about exercise.
Yeah, this comes up a lot, and as you and Carrie have said, our approach is evolving because we're learning from the registries. And I think, when I see a patient in clinic, it's important, first of all, to see if we can learn more about the genotype. And as been mentioned here, exercise may be a potent trigger, for example, in long QT1. And if a patient is taking their medications, we know that you can, potentially really reduce their arrhythmic risk. So I think this is where it comes, where you spend time in clinic talking to the patient, and it's really about shared decision making, to understand the risks, to make sure that your patient is complying with the medication. Certainly, I think we are a bit more liberal with regards to what we're allowing patients to do. I remember when I was a fellow 12, 13 years ago, it was very restrictive with regards to what we thought patients should be doing. But that certainly has changed a lot. And you mentioned Dr. Ackerman, and there's been some registries. So I think things have evolved. The other thing is that, the stuff that you showed, Dr. Goldenberg, about risk stratification, putting together the genotype, the QT interval, whether it's a poor or non-poor mutation, all of these things I think need to be put in to try and get the patient the best estimate of their risk. And so I think it's really shared decision making at the end of the day.
Any further comments, maybe?
Yeah, I think most of this major points have been made already, and I think maybe the bigger picture here is, rather than understanding long QT as one condition, we know that there are various subtypes. Rather than treating long QT as a single disease entity for all patients, we now can tailor and individualize the treatments for particular patients. And as we learn more and more, and as we accrue data on people, if you will, brave enough to have high-level exercises, we also are starting to realize better that, yes, it may be easy for providers to say, oh, no, you shouldn't do competitive sports. But I think we're understanding better on the other side of it is that, these competitive sports, they're important for patients and maybe for their families. Some of them are diagnosed when they're professional athletes. So these are actually their means of living. And so gathering these data to have an individualized approach will be the important part of it. So.
Great. Question which was submitted earlier by our respectful Huang family about what is the current protocol for children, and I would probably broaden it to patients who test positive for long QT but have no cardiac issues. You mentioned already some people who may be in your talk.
Yeah.
So positive for long QT gene, but they don't have any symptoms or anything. What would be your approach, whether it's child, as in this question, or even adolescent or adult?
So we need to distinguish, because as David mentioned, I try to stress, long QT is not a single disease. If we have genetic testing, and even though the QTC is normal, there's no phenotypic expression, we still know the genotype, the mutation, the sex of the patient, because women and men have a different risk during different time periods, and we can further assess the risk. As general, the guidelines recommend today to give beta blockers to all LQTS patients. But there's now a new paradigm that has not been implemented yet into the guidelines, in which very low risk patients do not need any therapy. For example, if you take a patient who have a very low risk mutation, let's say a male patient with after the onset of adolescence with LKT2 with a non-POL mutation with QTC of 350 without any cardiac event, there's now a new paradigm of no therapy for this, selected no therapy in very low risk patients. But you have to remember that right now the guidelines recommend beta blockers, the specific type of beta blockers, non-selective at the highest optimal dose tolerated for all NKTS patients, regardless of phenotypic expression. But this is the low risk population. On the other hand, the very high risk patients, despite lack of phenotypic expression, for example, patients who have a high risk mutation, women after the onset of adolescence, with a POL mutation, even though they don't have currently a phenotypic expression, they should still deserve the highest risk of the highest dosages of beta blockers because they still maintain a very high risk. So again, it's not a single answer. You have to continue to risk stratify the patient personally.
Sounds good. Another question which came earlier was about safety of long-term beta blocker treatment, and especially in infants, and whether this might have some impact on brain development and psychology. I looked just of curiosity at this topic prior to the meeting, knowing this question coming, and I couldn't find that much on the topic. However, there is one or two papers on infantile hemangiomas, which are treated with beta blockers. And long-term treatment in these infants are not associated with any abnormal signs or brain developments measured as could be measured by questionnaires and other, and by any cognitive deficiencies. And this was probably most pertinent to our topic of long QT children being treated with beta blocker. And as you are treating children too, David and Mehmet, are there any other concerns in terms of long-term treatment of beta blocker? We know that some people may be fatigued, may have some various other side effects, but in terms of overall cognitive function and brain development, any concerns?
I'm not aware of any really strong data to suggest that there is some long-term detrimental effect. Beta blockers as a class, they're used for multiple things, not just really for long QT syndrome, but it's used to treat arrhythmias in other patients. It's used for blood pressure. It's used for other reasons, treatment of neurologic disorders sometimes. So as a class, they have wide use in medicine. I'm not aware of any long-term data associated with adverse outcomes as a result of it. Now in utero as a fetus as a state, yes, there's some evidence that it may be potentially impactful, but beyond like as a toddler, as an infant, in adolescence, I'm not aware of any data. David, do you know?
In fact, propanol is safe during the pregnancy. On
Yeah.
the other hand, we have seen in the registry that discontinuation of beta blockers leads to a rebound
Yeah.
and an increase in the risk of life threatening events. So we should be very careful. If someone wants to discontinue beta blockers for any reason, they should consult with an expert
Yes.
if they have long QT syndrome.
Yeah, I think we don't treat a lot of very young children, but I think based on what we've seen in our pediatric pediatrician colleagues, is they tend to, of course, look at the EKGs, and if there's any genotype or family history available, they'll weigh those against the clinical presentation. They often tend not to treat as infant, and later on in childhood, they start the beta blocker maybe even 5-6 years onward. But yes, I agree. As far as I'm aware, we do use beta blockers for many patients with congenital heart disease at very young ages, and we do not have concerns about long-term side effects with those patients.
So another question which was about children, again, because there are some mothers and grandmothers in our audience. It's about treating young children in terms of managing them from the standpoint of participation. And the question is also about some studies on children and twins. We conducted, Dr. Goldenberg and a couple of other people conducted specific studies on children up to age 13. We categorize them 13 or 15 in various publications that were dedicated and trying to address, to the best of our knowledge, what is the difference. As I mentioned at the beginning, in one of those studies, we found that only LQT3, speaking about genotype, children, they have higher risk, whereas LQT1 and 2, they didn't show that much increased risk. I'm not aware of any particular study on twins, because part of the question is about whether we have any systematic study on twins. We have, however, in our record study on siblings, and we've done analysis on siblings, and analysis of this data on siblings show pretty much that patient history is more important than sibling history. There are some exceptions. We have some families which were particularly symptomatic, where we knew about death of one sibling and subsequently another sibling died. Yes, we have such cases like that, but general analysis of this data, which was done probably close to 20 years ago, was that given patient individual history of QT, syncope, treatment of beta blocker, adherence to beta blocker was much more important than knowing about sudden death in family or sudden death of sibling. So this is what I can say. Any comments on that topic from anybody further?
I guess as opposed to other genetic inherited arrhythmias like Brugada and hypertrophic cardiomyopathy and PLOQT, we also need to again to look at the specific patient individual more importantly than the family history. So if the patient has a normal QTC, no history, low risk mutation, and the sibling had a cardiac event, this is more patient specific and individualized assessment. This is more important. So we need to stress that, but anything needs to be taken into account.
Yes, go on.
Yeah, I think, of course, whether if the twins are fraternal twins versus identical twins is a very important distinction as well. If we can draw parallels from other conditions that we've learned, hereditary arrhythmias, that they're all hereditary arrhythmias, we have clinical experience of a different hereditary arrhythmia condition, arrhythmic right ventricular dysplasia, in a family, very strongly manifested in one family. but within the family, there's one set of identical twins, and one sister had it terribly affected, very advanced heart disease, and but the identical twin sister, did not have any manifestation of it until well in her middle age. I think if we can draw parallels from that, even with identical twins, there's going to be other factors that will be modifying the expression of the genes.
Okay, let me focus on the question which is in the chat. Last question about the genetic testing. So, question relates to the fact that some testing was done years ago, and second part of the question is that genetic testing, as you already mentioned, could be eventually normal, could be borderline, could be pathogenic, could be called variant of unknown significance. And as you commented on that, this is still challenge for all of us, at least as I see. The genetics of long QT and other inherited arrhythmias is still evolving. We are still learning, and we have this, let's call it arbitrary definition that some mutation is pathogenic, and this pathogenicity is based on some reported in the literature data that there was a family with that mutation, there was some sudden death in this family, there is some inheritance proved, and on top of it, in some cases, they have some preclinical basic science data supporting that this mutation impairs ion channel. This is pretty much what it is in terms of how pathogenicity of mutation is identified. Unfortunately, as there are hundreds of mutations, we don't have currently ability to publish every possible mutation found, and these days literature and journals are not interested in publishing one family with given mutation with 2 sudden deaths and 3 syncopal episodes in family, because it is of less interest to journals, so it's harder to really publish it. So therefore, there is some kind of insufficient penetration of this potential information on given mutation toward public. And therefore, those various databases, and there is like 30 of them in the world, they also are searching about how to define pathogenicity. They look at the literature, Medline, online, and they look, okay, is there anything written about given mutation and was associated with sudden death or not? And is there any proof for physiologic effect? So bottom line, we are still learning, and my view, as I'm expressing my view, is that we cannot guarantee for sure that given so-called VUS right now might not be pathogenic if some other family is found. As Dr. Mike Ackerman, who is very expert in the field of long QT, inherited arrhythmia, as well as genetics of these cardiac disorders, he also tries to look at neighboring mutations. So if new mutation is not described and is eventually in the region which was not associated with any arrhythmias known to in publication, there is high likelihood that this is benign mutation, but it's uncertain. So this would be my comment. I'm happy to hear Ilan's or anybody's further comment, because the topic is constantly on the table. No more comments?
No, I mean, like you mentioned, Perry mentioned, when we send out genetic tests, we do get results that may say, variant of unknown significance, and then it gets updated later on. We'll get a notification that what was thought, where there was some uncertainty, now based on additional data, now it's established that this is disease causing. And I think, this is obviously an ongoing, evolving field. Clinically, I think the question with regards to what do we do clinically, I mean, I think it again depends on the QT interval, depends on the presence of syncope, family history, you know, you try to put all of that together. Because again, even having a gene mutation, the penetrance, the clinical manifestation of that may be limited. And you know, and Dr. Goldenberg has published and talked about this. So it really requires a in-depth assessment, you know, the patient's symptoms, presentation, the EKG, and where we have it, the genetic information. But this is, again, sometimes not just black and white, you know, it is an area of discussion and follow-up.
It certainly, the genetic testing certainly can help, but that's kind of where the gray area has come in when you get someone that clinically presents a certain way, but then they come back gene negative. And so what, you know, what do you do? And that's where it can be challenging. And we just say beta blockers.
Yes.
Yeah.
The Sears stratification, which we described today, including this LQS calculator, which we discussed earlier, is also a possibility to look at the value of gene information versus QTC. We know already, based on our models, based on models developed by Italian colleagues, Dr. Priori or Dr. Schwartz, or other experts in the field, that still manifestation of disease, as you all are saying, QTC, the presence of prior syncopal episodes play a role, but also what we know from number of encounters with patients, that adherence to medication is extremely important. Gaps in beta blocker coverage are very important, so we should stress that. There were a couple of questions regarding deafness. We have done some work on Gerber-Lange-Nielsen syndrome, which is very rare form of disease because it requires kind of two alleles, two mutations to really cause deafness. And it's usually much more significant in terms of presentation than LMQT1, 2, and 3 alone. So if you have mutation coming both from mother and father by pure chance, this would be kind of aggravated in form of Gerber-Lange-Nielsen. It doesn't have to, but could be, and this is associated with deafness. There is some research indicating that the same LQT1 channel operates in our ear and governs our hearing. So whether I saw the question whether LQT1 people might have potentially with age impaired hearing, I don't know that for sure. I'm not aware of any systematic research done in this case. I know that people look at mutations years ago. It was probably 10, 15 years ago, and they didn't find that much association. But again, it's not my field of expertise, so I cannot know for sure. Anything you publish, Ilan, also we publish with Peter Schwartz on it, you publish on Gerber-Lange. Any comments?
No, I want to go back to the fact that genetic testing is important for risk stratification, but there are two options. If we identify a mutation that is genotype positive and we know about it, we should incorporate this in the management and the risk assessment. If it's unknown significance, or if it's negative, we should, like Dr. Aktas and the people here just said, just continue to treat the patient based on a phenotypic expression. But patient with JLN or congenital deafness have a very high risk, especially during childhood. They should be treated very aggressively, like secondary prevention patients.
We have another question on children right now showing up in the chat room about early treatment, very early treatment, and we speak about children when their cord blood is taken for genetic testing, and in a couple of weeks they have a diagnosed long QT syndrome, long QT1 in this case, and is it normal what is done with newborn with long QT? Now, this proactive cord blood testing at that early stage is a sign of really good medicine these days, because it was impossible years ago. and acting on it quickly plays a role. We know that some of the very young children may show some prolongation of QT even if they are healthy. Why I'm saying that? Because we have some research published partially by Dr. Schwartz in Italy, but also by others, that heart is still maturing in terms of ion channels in first few weeks after birth, assuming term birth, and QT assessment in first 3-4 weeks could be misleading and showing with fast heart rate showing too much prolongation. So we always are a little bit cautious in assessing long QT in first couple of weeks of life. But obviously, if somebody has genetic proof in first 2 weeks, it's again advancement of the science and medicine, and somebody should act on it. But in case it's not possible to do it right away, we try to be cautious and try to evaluate. As you, David, and you, Mehmet, may comment, some of these children develop some slow heart rate due to some blood, and therefore they may be also treated because of this. Yes.
Yeah, I mean, especially young patients' medications, beta blockers sometimes aren't very well tolerated, and dose titrations may be necessary. And so that does come up for sure. I think the question here with regards to treating so early, and it depends on whether or not the ECG really is showing QT prolongation. I suspect the fact that they had genetic testing performed along with initiation of therapy, to me would suggest that they're probably clinically also manifesting significant QT prolongation.
It's going to turn on. Because it's turned on.
I think that these are the most questions. I wanted to stress that we have, as we did in years before, we will provide slides and talks on our website, and we will try to eventually share with everybody. I see that additional question. Yeah, I think we addressed that. Okay. So it's 4 o'clock. We promise everybody that we will stop at 4. And thank you for joining us on this Saturday afternoon. And thank you for everybody here trying to help with this educational session. And as I mentioned, we will be happy to share it by our website for people who could not make it today. And we appreciate every family, every patient contribution to our registry for years, working with Bonnie, Becky, Chris, and helping us updating our record, because it's essential to do proper research. Any other final comments?
No, thank you. It was great, and thank you everybody for participating. The questions are important, and we want to continue this interaction continuously. We're going to have this on an annual basis, but if you have any questions for us, this is what we're here for.
We have special channel of Bonnie, Becky.
It's going to be
Thank you very much, everybody.
Thank you.
Thank you.